afternoon, everyone, and welcome to the Campus Lisa webinar series. My name is Angie Liu, and I'm from Information Technology Services. I will be your show host for the hour. Before I introduce our session of the day, I have some housekeeping items I need to go over with you. This session is being recorded with live captioning provided by Susan Thomas from eCaptions. It will be available to view on campuslisa.ucsd.edu. This presentation will be about an hour long, with some time at the end for Q&A. Please use the Q&A window at the bottom of your screen to ask questions throughout the webinar, as chat will be disabled. You can also comment and upvote other people's questions. Our session today is Building with AWS. UC San Diego Health initiates a clinical workflow around an experimental procedure aiming to detect COVID-19 signs via X-rays. Andrew Greaves, the Enterprise Cloud Architect from Information Services, UC San Diego Health, is here to kick off the session. Let's all give a warm virtual welcome to Andrew.
Thanks, Angie. I really appreciate it. And I wanted to start off by thanking the entire Campus Lisa team and ITS for putting this together, because it's a fantastic opportunity, both to present this exciting material, but also to hear from others across campus and their very cool projects. So I will be talking primarily about the infrastructure side that is provided by UC San Diego Health in the AWS environment. I'm joined with Dr. Brian Hurt, who's from the Department of Radiology, who's going to be talking a lot more about the AI implementation and radiology in general, and how this in particular has helped facilitate a lot of these clinical workflows that supported COVID, as well as Jit Bhattacharya, the CTO from Expertech, who is one of our premier AWS third-party contractors. So to give you a little history and background of this AI pipeline development, if you remember back when COVID was kind of first hitting the news and hitting the United States, this was the beginning of March, March 21st to be exact. We had a shortage of PCR-based testing that was available. So it was really important to be able to prioritize testing. We needed a way to quickly identify high-risk patients. And so we reached out to our clinical departments to look for options. And Dr. Mike Hogarth, our clinical research information officer, happened to see a presentation that was given at the Radiology Grand Rounds and thought this would be a perfect match. And basically because the AI that he developed has really it facilitates a very easy way to identify pneumonia. There was concerns around, staffing and what if everybody got COVID, and who would be able to easily identify on X-rays or other mechanisms patients that had COVID. So we'll dig deep into that in the next slides, and to kind of set the background for what it means to be in this HIPAA compliant environment in AWS. There's a couple of regulatory laws that are in place that kind of set the tone for things like protected health information. You've heard of HIPAA before. That was the 1996 congressional law that was passed that basically creates a set of rules or policies around dealing with PHI. In particular, because it's a policy, there's only really two technical controls that it specifies. No generic login, so no doctor. You had to have specific auditable individual user accounts, and that encryption was required in flight and at rest for that data. And then there was also this term of a covered entity, which basically means anybody who deals with this data, who has health plans, health data clearing houses, or who electronically transmit health information. And then in California, there's a follow-up law, the Confidentiality of Medical Information Act, or CLIMA, in 2009 that provided some more stringent guidelines, as well as specific personal, administrative, and civil penalties So that's the line in the bottom right-hand corner. It really puts some teeth into those rules, regulations, and policies. So with that as a background, I'm gonna pass this over to Dr. Brian Hurt to talk a little bit about the radiology, the AI process, and the algorithm that he developed.
Yeah, thank you very much, Andrew. This is quite a pleasure to be here and join everybody. You know, I am a radiologist and I do research, and I do translational research. And one of the, for things that involve software, invariably software engineering is a huge piece, how you actually integrate it if you actually want to affect patient care. And so that has really been an exciting part of this work, which I will talk about. But just to kind of set a background about myself, I'm a resident, which is a post-medical school doctor in training for radiology here at UC San Diego. Prior to that, prior to medicine, I worked Wall Street and NASA. I did a lot of machine learning and image processing in that world. When I came to UCSD a couple years ago, I came to do, I kind of been doing some driverless car research, and sort of got into this AI. How can we apply it to things in medicine? And X-rays is a very straightforward, at least from a data perspective, a way to approach it. It's a very common modality we use in medicine. And so today, this is what I'm going to talk to you about. It's pneumonia detection on chest X-rays. It will become clear what that looks like in the very shortly. So first, what is radiology? Really, according to Wikipedia, it's the medical discipline where we use medical images to diagnose and treat diseases of humans and other animals. We use X-rays on the left. We use CTs, which are three-dimensional X-rays, so you can kind of plane the body in any direction. It's a very common modality we use all the time, even in COVID. Ultrasound for the little babies and a lot of other reasons to get ultrasound. We use MRI, which is very useful for the brain up here on the upper right, and then the abdomen for other things. And we also do procedures under X-ray guided, so you can inject in contrast, which is essentially shows up as dark, and you can see where you are in the body. So these are things we do as radiologists, how we intersect with the other medical colleagues that we have. And so our role in COVID really is imaging and how it supports a COVID diagnosis. And principally, it's X-rays and CTs. So I'm not going to go into a huge This is a real patient that came to UCSD. He was a 51-year-old pilot, had 3 days of flu-like symptoms, unknown COVID exposure, had that initial chest X-ray, didn't get seen, wasn't interpreted by the radiologist as pneumonia. He was sent home, but he returned the next day with shortness of breath, and he got that 3D X-ray, the CT, and it sure enough showed evidence of COVID, which is essentially these kind of grayish areas in this black lung, which black lung's normal. So you on both sides, 2 lungs. And so that supports the COVID infection. Patient decompensated a little bit, didn't have a breathing tube, but was discharged after 5 days. And so the role of radiology is to kind of help dictate how severe some of these COVID infections can be. And X-rays are a very important tool, and same with CTs. But with COVID, as Andrew alluded to on the outset, in terms of disaster planning or surge planning, if you will, what if there's a lot of people in your waiting room with similar symptoms? How do you handle the same situation if it happened tonight? What if you're a small community hospital? So these things are things that we were thinking about. Now, we're not trying to use AI to diagnose everything with COVID. It's just one part of the process, and because medical decisions really are multifactorial data over temporal courses of data, different kinds of data, including imaging. But AI may help us to kind of triage or kind of prioritize. And so this is the same patient, that X-ray, got a CT. Before I go here, let me turn my video off if that helps. So the patient got a CT and showed the pneumonia. Well, our X-ray tool, but the CT takes time, and it's really not really practical with surge certain demanded. If there's a lot of patients in the emergency room, you have to clean it. It takes about 45 minutes between patients, so it's really not practical in scale. So X-rays become really the modality of tracking things, and our AI algorithm that myself and Dr. Shao, my mentor here at UCSD, we built is a tool that it essentially predicts, overlays a color map representation of where pneumonia will be. And the strength of the color, the more orange it is or purple, the stronger likelihood it is. So this patient's initial pneumonia was picked up by AI, but was not picked up by the overnight radiologist. So kind of diving a little further into the development of this particular AI model, really, but kind of, if anybody who's done AI, really it's driven by the problem. And in our case, it's, the clinical problem you're trying to solve. We're not trying to solve things like, managing the patient's care more holistically. This is just, is there evidence of pneumonia on the X-ray? So draw pneumonia. These AI algorithms are pretty data greedy, both in terms of how many X-rays you need, but also you have to sort of guide it. Where is the pneumonia? Somebody has to actually draw, in our case, where pneumonias are. That's not something that scales very well, generally speaking. I'll discuss a bit how it works and then how you build it. And this bottom is really it's not really linear, but there's a lot of feedback that happens. But you start on the left with the clinical problem. A lot of the research part is this blue-gray area. And then once you get it into a state that you like, you package it up, and that's kind of where you call on Andrew and Dev and Jit to help us deploy this in AWS Cloud. So, but before we talk about AI, this just kind of come back to basic. This is like the canonical machine learning example for people who may not be adept with machine learning. Linear regression, so Excel curve fitting. You can do a line, and really what it does, it takes two sets of data and it creates a linear relationship. So you choose a linear function. So in this case, we're fitting a particular population's latitude with that population's mortality, and it has a linear trend. So that regression allows you, for a given latitude of a population, you can predict the mortality rate. And that's essentially what you're doing with AI, but it's a fancier way to do it. So, why is it so special? AI, in contemporarily speaking, are neural networks. It's a class of machine learning models. And the function, instead of a linear function, is this very large neural network, which is complex, can handle a lot of different complex relationships between data, which in our case are images. And it can map an image to a prediction. So it can be a prediction as in a number. So what I'm showing down here is there's 76% likelihood that this patient has a pneumonia. That could be one output. Other outputs could be images, color images like we're doing. And like I've said before, to build these things, it requires a lot of data. And there's been, talk that they're sort of black boxes and hard to understand how it's working. And one of the ways I have tried to illustrate this is actually kind of looping through this iterative training process. So the training process, you expose the model several times over and over again with the X-ray. It makes a prediction, and then based on the prediction and your known pneumonia, where it is, you can get some error, and that error can be used to iteratively change the neural network or the weights to make it more accurate. And so, Andrew, if you want to just hit play on the left button there. Oh, okay. It's okay. So yeah, this is just a animation here of this neural network learning where the lungs are, which are yellow, the heart's purple, the airways, the breathing, what you breathe through is in orange. And what this shows is a collapsed lung, which is the blue part, and that's lung in between the chest wall and the outside the lung though, so it's compressing the lung. That's bad. You want that, you want to take that air out. So that kind of shows the model learning over time, iterative time. So in our case, we are going to coin the term augmentation of the radiograph. And this is really, I think, the key part of why our AI is very clinically useful. Instead of giving a number or whatnot, we actually just overlay a color that each pixel in the X-ray gets assigned a probability of pneumonia. And that you can, downstream of that, you can collapse into, is this patient having pneumonia or not, which can be useful for a triage type of setting. Say if you're rank ordering a list of which patients I should look at first as a radiologist, that's very helpful, or just to flag the provider that there might be pneumonia here, which is typically how some of the AI tools that we've used clinically here work too. So how do we build this? It's, like I said, it's data intensive. In this particular model, we used a public data set, 25,000 X-rays. And each X-ray has potentially, if there's a pneumonia, a set of boxes, these blue boxes that were created by, hand-drawn by radiologists from around the country. And this data set also contains normal and then abnormal, but not pneumonia cases too. So it's got a very rich set of, a diverse set of images, which you have to discern pneumonia from. And so we take this data to train a model, and the results we get, Andrew, if you want to go to the next slide, are we build the model, we apply it to some example cases here that weren't used to build the model. And on the left panel, we have pneumonia that was predicted and was also annotated. So the top row here is a case of a patient has pneumonia in both lungs. The black lungs are not as black. And the radiologist drew that, as well as the model predicted both sides. The second row, it's an outpatient, got a very subtle pneumonia on the very small one that was also picked up by the AI algorithm. And then a kiddo at the very bottom was picked up too. As a negative control on the right side, we have cases, a normal radiograph on the right top row was also, did not really show much of a pneumonia, and then another abnormal case, but was not shown as pneumonia. So it gives you some discernment, at least visually. But scientifically, you have to do this across the board for like a collection of data sets or a collection of X-rays. And so we kind of divide it into a classification and how well it localizes it. And the left side is classification. In medicine, we use ROC curves, receiver operator characteristic curves. And they are a classic test, or classic metric used to test the diagnostic ability of a test. It's in some ways the accuracy of the model. And for pneumonia and X-rays, it's not really a slam dunk problem. So a perfect diagnostic test would have a right angle. So you'd have a straight line up and then a straight line across. Ours is, pretty good. Coin flip is the dotted line, the dotted black line. So we're doing pretty good. And this, as it relates to the literature for the same data set, it was at the time best, kind of the best classification in pneumonia. And then really the strength of this is how well are you able to localize it. So it's one thing to say there's pneumonia, but how can you conclusively say, oh, it's being localized to where the actual pneumonia is? And over 60% of our test cases that had pneumonia localized with over a 50% overlap, which uses called the DICE score. And so that was a substrate for a paper that we published back in January, right when COVID was starting to hit. And at that time, Wuhan had some case studies that were coming out with some X-rays and CT scans. And so at that point in time, we decided to, apply this model and see how it would work. And so with Dr. Shao, we just took some PDFs off the internet, varying resolution of X-rays. And so we have case reports from the US and China, early COVID days. And what this is showing you is some are terrible spatial resolution. Some are great resolution. So and these are also from US and China, different vendors of x-rays. And so this shows you for the top row in the US, this is one patient over the course of time. We're predicting a pneumonia, and this is real. This tracks the pneumonia if you were to follow it, if you were asked a radiologist to follow the pneumonia. RA is predicting it there. So it has a longitudinal temporal course quality that's very promising. And then it also works on cases in China too, like I said. So it works on their machines, what they use there. And it has, COVID pneumonia has a lot of different looks to it. So it's not like, picking a face out of an image. And so kind of with that, we decided, we were really excited really at that point in time. This might be more generalizable than we think, this model. That's one of the big concerns with AI. How will it work on my hospital? And so that's when Dr. Hogarth approached Dr. Shao and I, and that's how I got connected with Andrew and the expert tech folks. And Andrew will take you through how we took that model and brought it into the hospitals such that our physicians like me and every physician and nurse can look at AI in real time as the patient's getting scanned.
Thanks, Dr. Hurt. I'm going to talk to you a little bit about AWS, the shared responsibility model, the HIPAA boundary architecture, and then start to kind of work through that AI architecture that we put together to support the wonderful work of the radiologists. So just to kind of cover bases here, there's a thing I mentioned earlier, the concept of the covered entity and responsibilities around protecting EPHI. So there's a notion of this business associates agreement, which is really a legal extension of the covered entity to third parties. So one of the things you have to have in place with any of your third-party vendors, such as Expertech or AWS, is this business associates agreement. And there's very specific language around it. There's one that is, because all of the UC Healths are one covered entity, there is one BAA that covers all of the UCs once it's signed at the UCOP level. So another important part of this is this shared responsibility model with AWS. So we have the top part here in the blue is really everything above kind of the physical infrastructure and the networking. This is our responsibility for protecting, while AWS, because of the covered entity in this BAA, is responsible for all these other parts, right? So the physical security around their data centers, making sure that compute isn't failing, storage is provided and highly available, things like that. Our responsibilities are for the applications and the applications that run in that environment and making sure that we're securing everything that our users are doing in that environment. And then another important piece with this is all cloud vendors have HIPAA eligible services. And what does that really mean? That means that it is eligible and can be HIPAA compliant, but HIPAA compliance means that the CISO or the Chief Information Security Officer has reviewed and signed off and has visibility into the environment and what's going on in that environment. So in our case in UC San Diego Health, that's Ken Waukee. So his group, the Information Services Security Team, reviewed all of the AWS environment, and then we review each of these HIPAA eligible services to make sure that what we're doing is HIPAA compliant within that environment. And it really is our responsibility, not AWS's, to make sure that what we're doing isn't somehow violating, a security principle, or we're not inadvertently not encrypting something. So with that, I'm going to pass this off to Jit Bhattacharya, the CTO from Expertech, to talk about a little of the baseline architecture that we put in place to provide this HIPAA eligible or HIPAA compliant environment with HIPAA eligible services.
Thanks, Andrew. So I'm going to discuss a couple of important concepts of the HIPAA environment, and one of them has to do with the HIPAA boundary, right? So think of that as a fence around the property that you're trying to protect. So in our case, we build that fence using two high-level concepts. One is that of an organization. So we use an AWS organization. So any account that needs to come into this HIPAA environment has to join that HIPAA org, right? And we enforce certain policies across the board for all accounts using that organization structure. And the second important piece is the networking around everything that's within that environment. And that is controlled by a Palo Alto virtual firewall in our case. And that connects to the Palo Alto on-prem firewall at UCSD Health. Now, what this does is there's two different concepts. One is that every egress and ingress into the HIPAA environment has to go through that virtual Palo Alto, right? And then all UCSD Health policies for networking can be enforced out there. The other concept is that of what's called a transit gateway, which allows us to plug and play, plug in any account that needs to join in a hub and spoke model without having to go into a mesh networking type of a scenario. So yeah, we can go to the next slide, Andrew. So now that we have built a fence around our property, we need to have a protected entryway. And that is where the concept of a bastion host comes in. Any entry point that requires any kind of privileged access, like developers, DBAs, system admins, have to go in through a bastion host to get access to any of the resources within our environment. Right? Now, any application access can go into and hit the application, but it still goes to the Palo Alto firewall, but only to the application, which is a very controlled access. Right? The other concept that this slide shows is that of an isolation. Every research group in a HIPAA controlled environment has to have an isolation. So every researcher has their own account, and their bastions sit in a subnet that is isolated from every other researcher and can only get access to the resources they're approved for. And with that, Andrew, you want to take on?
So one of the things I wanted to kind of cover was just a little bit of the timeline again. So remember we were approached in late March to kind of take this mysterious algorithm that Dr. Hurt had developed with the Department of Radiology and figure out kind of how we could develop a pipeline to implement this, leveraging obviously his AI algorithm. So one of the things we wanted to do is make sure that certainly our AGFA impacts is our picture archive system that we use at UC San Diego Health. So a patient comes in, gets an x-ray, that goes into, the order goes into Epic, the images go into this impacts. We needed to be able to get the image out, ship it into AWS somehow, get it analyzed, and then get that secondary image capture that comes back with that the kind of yellowish overlay, and get that secondary image back into the PACS. And so with about a 7-day timeline, we sat down with as a team and kind of figured out what pieces we needed to develop. The other thing that we needed to make sure of is that this was scalable to other hospitals. While it's in our HIPAA compliant environment, and they may have a different HIPAA compliant environment, we needed to make sure the general architecture was something that was scalable and portable. And then so, like we said, we sat down over the course of the first couple days and mapped this out. So, our plan was, we knew we needed to work with our clinical imaging team in information services because we're not PACS experts, nor do we claim to be. We understand that what a DICOM image is, but we don't understand all the intricacies around it. So we had to rely on their expertise there. We certainly had to rely on Brian's expertise for the AI algorithm. And then we leveraged things that we already knew about in AWS. Now you see these Ombra gateways. These were EC2 instances that were stood up and managed by a company called Ombra. Ombra deals with HL7 and DICOM messaging. They're very fluid with kind of the process for that. So since they were already third parties that we were engaged with, we brought them in to manage these incoming and outgoing gateway servers. And functionally what they were doing is taking what was coming from the PACS and sticking it in an S3 bucket or object storage in Amazon. And then from that point, we needed to figure out kind of, okay, now we've got the image in the bucket, what are we gonna do with it? So we triggered events inside the bucket to create a SQS message that lives in this SQS service in Amazon. And then we needed to figure out, okay, well, we've got a message here that says, yes, you've got an image. How do we get that image then into the AI algorithm container and make sure it gets processed? And then once it's processed, where's that outgoing image going once it lands in this S3 bucket? So we knew we needed to develop some sort of file management type application to facilitate between the algorithm containers and the file management, along with managing getting stuff in and out of these S3 buckets back to the gateway. And what the gateway really does here for the incoming is just process that an image is coming in, stick it in the bucket. So we're handling everything on this side. Then once we drop the image into the bucket, this outgoing gateway was pulling that S3 bucket saying, you know, do you have any images now? Do you have any images now? How about now? How about now? How about now? Because time is of the essence, right? You know, you have these patients in the hospital, you've got a radiologist doing the read of the x-ray, really getting that secondary image back as quickly as possible was of the utmost importance. And here cost wasn't as big of a concern because, you know, people's lives were at stake. So with that, I'm going to pass it back to Jit and talk a little bit about that piece that I mentioned before, the file manager and the algorithm containers and how we kind of set up that infrastructure.
So this gives a high-level overview of the workflow behind this. And first to get into the infrastructure piece itself. So the analysis algorithm that Dr. Hurt built, you know, he did it he Dockerized it. And so what we have if you see in the bottom right, is that infrastructure where we are running 6 containers of that, you know, Docker image to parallelize, you know, processing those images. And we have an Nginx load balancer, again, Dockerized, that sits in front of it to be able to handle that parallelization, right? So that together is kind of like the black box that we are calling as the analysis container, right? So now the file management application that Andrew referred to was a custom-built, you know, Python program that we have. So on the left-hand side, as you see the workflow, once an X-ray is ordered and it goes to the AMRA gateway and comes into an S3 bucket, then it generates a trigger event to an SQS queue, right? So that's when the file management process takes over. That's the black box there. And what it does is it is continuously polling the SQS queue for a new file coming in. And once it gets it, it picks it up and does some basic housekeeping on the DICOM file. It is a DICOM file, you know, so it does some basic housekeeping and then sends it to the analysis container, you know, that I described, right? Now the analysis container can do, you know, there's 3 outcomes, right? It could be a bad file. It could be a good file with an outcome that, you know, is showing some kind of a, you know, pneumonia, or it doesn't, right? So in one of those cases, when it does find some kind of a pneumonia, it creates what's called an overlay file that, you know, Dr. Hurt and Andrew described, right? So once that is processed, the file manager then again puts it back into an outgoing folder in an S3. And also we capture all the information in the DynamoDB so as to, you know, provide auditability and, you know, making sure it's all, you know, run through. So now this whole process from generating an X-ray to sending that overlay file back on an average takes less than 5 minutes, 3/4 of the time. And so, you know, a doctor is actually able to look at the overlay file in a real clinical time, you know, as they're, you know, working with patients.
So one of the pieces that I wanted to mention that we have since modified, I mentioned the Ombra gateway and price not being that big of a consideration when we first put this in place. One of the things that we looked at is, this is EC2 infrastructure. This is, compute that's running round the clock, not the most efficient way to handle that. We thought, hey, what if we could remove the gateways and just use something like an SFTP process up here from the PACS into the S3 buckets. So fortunately, Amazon has a service called AWS Transfer for SFTP, and we had already been leveraging it other places in our accounts. And so what we did was we replaced the Ombra gateways with this SFTP transfer process, where we're allowing an application that's sitting up near the PACS to push the images down to us through this SFTP gateway, and then do the same monitoring process looking for outgoing files coming in this outgoing bucket here at 8A. And so all it's really doing is kind of polling, saying, hey, is there anything new? Is there anything new? And then when new ones are coming in, same process, it's pushing them down into this S3 bucket. And the same triggered events that happen for this SQS piece, we're pretty much rip and replace the Ombra gateways with the AWS SFTP or AWS transfer for SFTP service, which cut our costs down dramatically, as well as some of, not having to manage the underlying infrastructure because it's just S3 underlying and it's a managed SFTP service from AWS. So with that, I'll pass it back to Dr. Hurt to talk about how physicians adopted it and what they thought of it.
Yeah, so thank you. Great discussion of the architecture piece of this. So like Jit had mentioned, this takes about a few minutes to run. The actual AI part of it takes about 15 seconds to run. Most of it's the ingress egress because these X-ray files are pretty large. So the AI part's pretty smooth, and that's clinically insignificant in terms of time. So this has been up since end of March. We've been running it, obviously putting upgrades to it in terms of the infrastructure part of it. The AI itself's been pretty static in that time. And when we first put it up, we let, physicians, we send them a message, but it's pretty clear. You open up a patient's medical records, you can see this AI. And so our ED physicians, our emergency department physicians contacted us about doing a study, a reader study. And what they did was that over the course of the month, we just asked for each sort of case that came through, each patient that came through, a couple simple questions. First one, did that overlay help you as an emergency room physician? And then the second one, or I guess, was it easy to use is the first question. The second one is, did it help you in your medical decision-making? And then the third one is sort of how. And really the main thing here is it's very easy to use. I mean, that was our hypothesis leading up. You just show a picture. It's easy to digest if you know kind of roughly what you're looking at. You can quickly say yes or no, I agree or don't agree. Very efficient way to digest the AI. And in terms of contributing, we have anecdotes, yes, but 20% of cases where it actually changed the management of patients. X-rays aren't usually game changers in terms of patient management changes. So what optimum number is kind of unknown, but I would say 20% is a pretty solid, I'm pretty impressed with that number in and of itself. And this data is being, it's unpublished. We're trying to publish it shortly. And so that kind of leads into, after it's been a couple months, shortly after we released it, we got some press. This is from our own press, our own services, talking about this deployment of the model with Amazon and sort of this synergist, our team that we built. But it was also picked up at other places. I think the LA Times had an article and a few other news outlets. So we were pretty, not that that's what we're going for, but I think images are pretty powerful. And this is a very interesting work we're doing, translating this research into patient care and COVID. But so kind of what's next from the AI standpoint is really, kind of how do we build on it? Like I said, it's not a perfect model. There's a lot of cases where it misses. There's some cases where it overcalls things. And so how do you make it better? Well, the first obvious case is you give more data. And it's kind of tricky to get more data. We added our own UCSD x-rays as part of an IRB approved study. But we had to annotate them. So I wrote some software to annotate pneumonia. So we use that new data to update a model. And so this update hasn't happened in terms of improving the localization of pneumonia. And the second thing we are going to do, and we have done, is quantifying regions of involvement. And that's showing to be prognostic in patients with COVID in terms of their likelihood of going to the ICU, the intensive care unit, or getting a breathing tube, and even mortality. And so we can correlate these numbers, which are essentially the pneumonia probability at that part of the lung, and we can correlate to the aggregate amounts to those outcomes. And that can be a very powerful thing. So this is some ongoing research we're doing. But there's a lot of other things we can do with chest x-rays, not just pneumonia. There's a lot of different triaging things. So things that, things that have very singular answers to things like a breathing tube. So this endotracheal tube, where is it located? There's an optimal place. This chest tube and pneumothorax model, that's that dropped, collapsed lung that I showed you in the video earlier. That's the model. And then there's a feeding tube, and you kind of want to know where all these things are in the body. And this kind of color overlay is really a natural way for physicians, radiologists, clinicians, nurses even, to really quickly digest and get a nice sense of where one of these tubes or devices are. So this has been a pretty exciting few months for us in this regard. It's like I said from the outset, translational research is can be pretty hard to do, and with software infrastructure, we've been very fortunate to have information services with Andrew, and with the help of Dr. Hogarth and Dr. Longhurst that have endorsed this. And there's really an Amazon. I mean, we really couldn't do this without the generous support of Amazon. So Andrew, I'll let you kind of take it out here, and I'm available for questions.
Yeah, I'd be remiss if we didn't mention everybody on the page. They were all contributors in one way or another. And like you said, obviously Amazon was a huge part of this. In terms of getting this done in 7 days, I mean, it truly was blood, sweat, and tears with Expertech, Dr. Hurt, and myself. And even once we launched it, it was kind of round the clock baby monitoring to make sure things were running efficiently, looking at where we were getting errors and making some pretty quick fixes. And that's where Amazon also was extremely helpful in just providing support in ways that we didn't know we would need until we were there, and advice, because they really have a grasp of a wide array of areas that you don't know you're going to need support until you get there. And then I'd also be remiss if I didn't mention the Diagnostic Development Initiative that helped fund this. For a larger amount of credits, so the underlying infrastructure was at no cost to us, which was absolutely awesome. And so with that, I will pass it back to Angie, our awesome host, to start fielding some fastballs.
Fastballs. I didn't bring my
We'll
glove
see.
today.
Fastballs, fireballs, I don't know, something, screwballs.
Well, thank you guys. Ladies and gentlemen, it is that time for our Q&A portion of this webinar. I didn't see any questions come through yet. Anybody out there willing to throw a hard one at these guys? Step right up. Anybody in health want to throw an anonymous question their way? We're up for those too.
Well, we've either dazzled them or put them to sleep, one of the two.
Is there anything you guys want to share that maybe you didn't get a chance to during the presentation while questions come in?
I think I've said it a few times, but as somebody who's lives in this translational research domain, I think it's been really inspiring to actually work with pretty much, the team here. It's really a testament to the collaboration and kind of the teamwork. And I think with research, people can tend to kind of be in silos, but this was a case where we all kind of collectively got together and built this nice system that has really been quite impressive. And there's not a day that goes by that I hear about it in the hospital. Like I had a med student say, oh, she used AI on her rotations the other week. And so it's really, it's impressive, the sort of the swath of influence it's had here at UCSD.
And I think the fun thing from our side is, our responsibility is building out the infrastructure and kind of providing and facilitating the infrastructure for research purposes, and to have this natural transition from kind of concept to implementation within 7 days was extremely cool. It's not every day that you get to actually help patients and not be a physician.
7 days?
7 days.
All right. I did see
It's a long 7 days.
Yeah, like literally no sleep 7 days.
Oh, wow. Well, I appreciate what you guys are doing. I did get one question come through. What is the average airspeed velocity of a Latin swallow?
I believe it's 42.5 meters per second squared.
Oh, that's funny. Let's see. Oh, question came through. Do you train a separate model for children COVID image sets? Is there a difference in the accuracy of prediction among the adults and children?
That's a great question. So the short answer is no, it's one singular model. The data set I discussed had a subset of pediatric patients in there. And what's hard is they typically are lower performing because the whole image is say this big, but the kiddo's 20% of the size. And so it depends on how you process the image. So you could probably boost performance if you had some pre-processing upstream to kind of just crop out all the black space. But for this particular implementation, I didn't do that. So it's probably reduced, but here at UCSD, we have a dedicated children's hospital that this isn't running on. And our study's not IRB approved for people under 18. So that's not really of clinical importance for us right now, although it's an excellent question.
I guess the other question earlier was a joke or it had something to do with Hitchhiker's Guide and Monty Python. Sorry, I'm not cool enough to know that, but appreciate the question anyway. An attendee asked, does COVID present differently than standard pneumonia, and could the AI make a COVID diagnosis?
That's a great question. Initially, I think there was a big rush to characterize pneumonia and COVID pneumonia versus something else. It has a lot of specific features. A lot of COVID pneumonia tends to accumulate in the bottom of the lungs, but there's also other disease processes that do that too, that cause pneumonia. And so it's probably possible to have some sort of, say train AI, but to actually differentiate COVID pneumonia from pneumonia. I think that's not really the clinical question. Usually when I look at an x-ray or a radiologist will look at an x-ray, so what's the information around the x-ray? Was this patient around exposed to COVID? What are the risk factors? What's their history leading up to it? And so that's whether they have COVID pneumonia on an x-ray or just regular pneumonia, that doesn't really have a clinical, doesn't change how you interpret things clinically. So from my perspective, it's just pneumonia or not. And then you layer in other information to say it's COVID pneumonia, even though there might be specific imaging findings. But I think mostly it's about the other information that's not on the x-ray.
Thank you. Anybody else have questions? Don't be shy. Oh, from an anonymous attendee. does your application of AI with radiology have promise with detecting other illnesses?
Well, yeah, I mean, I showed some work with the chest x-rays. So one of the illnesses that air in between the lungs and the chest walls, the dropped lung, that's another form of an illness. There's other imaging modalities that we've used AI for. It's not, we haven't run it through this AWS application, but things like liver disease has some characteristic findings. A lot of heart issue, like sort of heart imaging, cardiac imaging is really ripe for artificial intelligence. And that's what my mentor, Dr. Xiao, is really big at. And so it's really across every modality. Imaging is a very nice modality to use AI on, especially in medicine. So really is a lot of different areas.
Last call, ladies and gentlemen. Maybe. Oh, here we go. Glenn Stroud. Yes. Would this have been possible without AWS? Ooh.
I think the biggest thing is it would be possible on-prem. It would be possible in another cloud environment if we had the HIPAA compliant environment already set up. So it's one of those things where it was the right time and right place. We already had AWS set up. We had the technical depth and expertise to kind of address it. But certainly, because it's containerized, it could be darn near anywhere that can support containers that you could handle the file management going in and out of. And that goes back to that notion of making it portable and scalable potentially to other hospitals.
That actually leads us to the next question. Have other hospitals implemented this? And if so, about how many?
Andrew, do you have a good answer for that one?
There are several others that are looking to implement it, but it's an extension of the IRB, so I'm not sure what the status is with the extension of the IRB. Several other UCs. I'm not sure about organizations outside of the UCs.
Yeah, we've had, I think UC Irvine they've implemented it. UCLA has it. And then I think UCSF also. So I think the IRB covers a lot of the UC. It's sort of UC-wide IRB. And then otherwise I think we've talked to Dr. Xiao, my mentor, he did his residency at Stanford, so he's got a lot of connections up there. So we're trying to get it up there. And I think MD Anderson also. There's other places.
All right. Is there anything you guys want to say? Any takeaways? We do have about 7 minutes left.
Yeah.
No, I just really want to take the time to again say thank you to the Campus Lisa team. This is such a cool event, and I know it's weird having it virtualized and not be on site and have vendors and cool giveaways at the end. This was a really great way to do it because I think it extended it out over a longer period of time and kind of gave us an opportunity where typically health has been maybe not as participatory as usual. Maybe it's because of proximity and we're on the other side of the 5 or whatever, but either way, this is just a great opportunity. And we really thank your professionalism and your team because it's awesome. We even had a rehearsal. It was like a rock concert. I was asking for pyrotechnics, but we didn't see those yet.
Maybe next time.
Next time.
All right then, well, this concludes our presentation. I'd like to thank the presenters for sharing their time and insights with us today. I would also like to thank our captionists and Rachel for helping me with the Q&A. Please refer to campuslisa.ucsc for more .edu for more information. And I want to thank you for attending. We hope to see everyone at our 7th and final Campus Lisa webinar next week. Have a great day, everyone.